My name is Susan Blacker, and I'm one of the directors at large for the American Society of Addiction Nursing. This webinar has been approved for one nursing CE through the California Board of Nursing. If you complete the survey, you'll receive your certificate of completion with the CE sent by email at completion of the webinar. All sessions are recorded and archived saved on the website. So if you've missed any, you can go back in and catch up. The CE is available for the live or on demand, and you will receive your certificate after completing the survey. All webinars are free to ASAN members. So I want to welcome you. Please keep your cameras on, mute your microphone, post your questions in the chat, and we'll get to them at the end. So now I'd like to introduce our speaker, Bill Carrick, who also happened to be the first president of the American Society of Addiction Nursing, is a certified addictions registered nurse and the past president of the society. Bill's an RN since 1981 with a focus on mental health and substance use nursing since 1983. He received his certification, the CARN, in 2009. He has inpatient experience with withdrawal management as a staff nurse, nurse manager, and program director. And he has experience with over 750 outpatient detoxes for the past 16 years as the founder of the Executive Recovery Coach Incorporated Executive Home Detox. He has been alcohol-free for the past 36 years and is familiar with self-help programs. These are the learner objectives. You'll describe 3 strategies for outpatient assisted detox and apply 1 advantage and 1 barrier to each option. Synthesize data from vital signs and symptoms of alcohol withdrawal and apply one of these 3 classes of medications that may alleviate the symptoms.
Okay, this is meant to be a fairly general review. It's my hope that this presentation encourages discussion and consideration of how we can assist a client outside the inpatient arena, in other words, the outpatient arena. Does anyone have any specific questions right now that you may want answered in this presentation? If you do, speak now and be succinct, please. Not hearing any, so I'll just move on. And why don't you mute now if you haven't muted already. All right. So right now, there's a number of levels of care per ASAM, or per the American Society on Addiction Medicine. They include outpatient, intensive outpatient and partial hospitalization, residential or inpatient detox, and medically managed inpatient treatment hospital. Now, I want you all to take a second and think about what is the primary determinant of where these clients fit in, or where a client fits in regarding the levels of care. The one primary determinant. And it's my opinion that one primary determinant is the client himself or herself. When you look at most of the literature that comes out of ASAM or out of the Department of Health and Human Services, what you really want to focus in on is meeting the client where they're at. And so, clients can be encouraged to go into an inpatient arena, and that's our desire. They can also be encouraged to go right into a hospital level of treatment. But if they're unwilling to, then really we have to look at outpatient treatment. One of the ways we can do that is do it yourself. What could possibly go wrong if somebody decides to detox themselves, So, little funny here. Who would you like me to call first, the electrician or the plumber? We have a lot of do-it-yourselfers in plumbing and electricity. We go to Home Depot. Why not do it yourself regarding alcohol detox? That's my last cartoon. So if somebody decides to do it themselves on an alcohol detox, this is not recommended, but this may be a step in the right direction. The Department of Health and Human Services, they estimate that 70% of people who get detoxed in any given year are doing it themselves. Really, only 30% are inpatient or medically supervised outpatient. And so a lot of people are doing it themselves. I would highly encourage or tell you, don't encourage somebody to do it themselves, but don't discourage them either, unless there are obvious medical issues. We always recommend medical supervision, some kind of oversight. And so then the next question comes up, do we do cold turkey versus an alcohol taper if we're doing a do-it-yourself alcohol detox? Now, cold turkey may actually work quite a bit for clients. They may have a very mild dependence, and cold turkey may work especially with binge drinkers. The body will let the person know if this is possible. If it becomes unbearable, then they're just going to drink again. And if they're white knuckling it, they're just going to drink again if the body's screaming at them. I also, the detox process, the body really lets you know what's going on. If the client is not so much a binge drinker, but is alcohol dependent, then it is possible to taper using alcohol itself. Now, this is very difficult with alcohol dependence. However, it can be done. I receive a lot of calls from clients looking for help, and for a number of factors, we may not be able to help them. Financial is probably one of the major reasons. However, they then ask if it's possible that they can taper on themselves. And I do highlight how difficult this is, but we've had a number of people who have call me back and say they were successful. They were able to do this. And really, while it's hard to make a recommendation to clients on how to taper using alcohol, it's the old countdown method, 10 drinks one day, or however many drinks they're doing in a day. You start there and you just count back and cut back and taper that way. I saw Adam on the call, Adam Barrett. So I suspect he knows about this program, but Dropkick Charlie's was a program outside of Boston in Acton. And they used to give you a 6-pack when you got admitted. And the next day they gave you a 5-pack. And the next day they gave you a 4-pack. And that's how they detox people. This was prior to the 1970s. So again, this can be done. It's difficult. It's rare, but this can work. Now, regarding office-assisted outpatient alcohol detox, this is with medical support and supervision. And so the question comes up, what is the support and what is the availability for supervision when you're looking at an office-assisted outpatient alcohol detox? When you're dealing with an office-assisted, this also gives you an opportunity for medication-assisted detox. And there are multiple options for medication when you're dealing with this. And the real question comes up to be or not to be. Do you add a benzodiazepine or not with office-assisted outpatient alcohol detox? So factors that come up for outpatient management are, what are the labs? Are they normal? Are they abnormal? And the labs, if they're abnormal, but they're borderline abnormal, that's really not a indication that the person can't do this on an outpatient level. Even if their LFTs are double what they should be, if they're twice the normal range, that's not an indication for an inpatient setting. It will not cause problems with the uptake of a benzodiazepine, for instance. So labs are important, but again, keep in mind, even if they're abnormal, they need to be significantly abnormal to make an outpatient detox taboo. What is the support network for the client? This is very important, and we'll get back to it. Is there acute illness, or is there poorly controlled chronic medical condition? Those things need to be taken into consideration. Is there a risk of DTs, severe withdrawal, seizure history? Now, the risk of DTs, if you're looking at an outpatient management, I don't know a whole lot of offices that would consider a client to be detoxed on an outpatient level if there was a risk of delirium tremens, meaning that they actually had delirium tremens in the past. I'll focus a little bit on DTs now. I really wish that they would change the name of this, because I get a lot of calls from clients who say that they've had DTs, but in fact, they never have. They've had tremors. And some of these people actually think that having the tremors could also be construed as seizures. So you have to pare this down and find out if, in fact, they actually have had DTs. One of the questions I ask to differentiate is when they tell me they've had DTs, I mention, so you've been treated in the intensive care unit when you've been hospitalized? And they say, oh, no, never anything like that. And if somebody has delirium tremens and they're in the hospital, invariably, I've seen that they've gone to the intensive care unit. So that's one of the ways to differentiate. Moving on, if they've had an intake of alcohol for a long period of time, let's say you're dealing with a 60-year-old and they've been drinking since they're 20, and they've been drinking a fifth of vodka for the last 30 years, that might be an indication that you don't necessarily want to do an outpatient-based detox. And severe withdrawal symptoms. It could be a number of the symptoms, but all of a sudden you have a very high CWA score even while they're drinking. So those are factors to consider. Also, barriers to office-assisted outpatient alcohol detox. This is intensive work. When you're doing an outpatient alcohol detox, you really need to pay attention to the client, and you need to be available to the client. And if you're not, I would highly dissuade any outpatient group to be doing this. Also, is there familiarity with detox? We're good at what we do over and over and over. If somebody hasn't done detox in a long period of time, then I would hesitate on taking on an outpatient alcohol detox. And what is the experience in doing an outpatient detox? So these are barriers that are there. Acuity and liability, of course, are barriers to the office-assisted outpatient alcohol detox. And also, I see a barrier as ease of washing one's hands. It's really easy for physicians and prescribers to say, you have to go inpatient. I'm going to wash my hands of this, and you just go somewhere else. And when you get back out, you come see me. And again, they're suggesting that they go to a place where there is familiarity with the detox. Detox is not rocket science. It's actually a fairly easy thing to do, but in my opinion, it's also an art. So the support network, when you're going to do this, that can determine how aggressive an outpatient detox can be. And what I'm talking about with a support network is, who does this person have in the home with them? Who does this person have to rely on. And who's at home? Are they home around the clock? How responsible is the person? Is the person that's a responsible person in the home, or supposedly responsible, are they actually drinking or using any other substances? So you really need to clarify who's going to be in the home with the client. If the client is home alone, then the clinician must really know him well or know her well. I certainly wouldn't recommend prescribing for a client that's going to be home alone. What is their background? Oftentimes, people that are assisting the client in the home have a healthcare background. It could be nursing, it could be medical, it could be in the allied health field. So you take that under consideration. And is there an ability to use tools? And those tools are the blood pressure cuff, the oximetry and pulse device, and SoberLink. So if you have the ability to use those tools, then this makes the whole process certainly better and easier, and it gives a sense of confidence. I will suggest something that we do on a regular basis is you have the client sit for 3 minutes prior to taking their own blood pressure, or if you're having somebody at home do this, you have the client sit for a full 3 minutes, and 3 minutes takes a long time. They're going to want to get up and move around, and right away that affects their blood pressure and pulse. But I would focus on making sure they're sitting for that period of time. Regarding future tools, I think regarding the support network, we're looking at wearables, and I have Bluetooth here. I do believe we could probably be doing some of this now, where the blood pressure is automatically sent to the physician's office. The oximetry does the same thing, but also the wearables will allow us to monitor the client in their sleep, monitor how much they're sleeping, and I suspect we'll be able to monitor their alcohol level almost on a consistent basis in the future from a distance, and that will allow for outpatient detox to progress in a different way that it's happening now. All right. So when people engage in the office, there's a lot of practitioners that do not want to use benzodiazepines if somebody is doing an outpatient-based detox at home and they don't have a nurse present. Some of the accepted medications, this was from a recent program I saw at ASAM, was from Dr. Weinger out of Rochester, New York. And he likes using the following medications when he's doing the outpatient alcohol detox, benzo-free. He likes valproic acid or Depakote, or carbamazepine, also known as Tegretol. These are anti-seizures. They help sedate the patient, and they work well, especially given HS doses. He likes gabapentin, that assists with sleep and mood stabilization, and it provides sedation. Clonidine is a antihypertensive. It decreases the pulse, anti-anxiety, assists with sleep and sedation. Of course, with clonidine, with all these medications, you're going to want to watch for the side effects. But with clonidine, especially, you're going to want to watch for orthostatic hypotension. That is an accident waiting to happen, again, especially if the client does not have the support at home. And he likes to use naltrexone regarding anti-craving medications. All right. Let's see here. Okay, so if we're going to add a if we want to consider adding a benzodiazepine, prescribers are reticent to add a benzo. There's an acknowledgement of a more serious detox process. If you do add a benzodiazepine, there's liability issues. You have an increased falls risk, and you have the potential for misuse. Again, if the person is not being supervised adequately and they start taking a benzo, they could get into a twilight sleep, wake up, not know what time it is, take another one, wake up 15 minutes later, not know what time it is, take another one. So physicians or prescribers are quite reticent to add a benzo, and I can't blame them. So what should be in place? In order to add a benzo, I think you have to have an irrefutable, responsible person in the home. So if we're talking about the literal management of a benzo at home, one of the options is that a responsible person holds the benzo at all times. There's still a risk to this because the client may insist on holding them themselves, and the responsible person may cave. But there is another option that some outpatient programs use. And that is that the client makes a visit to the office daily for dosing or renewed prescription. And this is a good opportunity to get the client into the office and to eyeball them, make a connection, and see how they're doing. This doesn't make a whole lot of sense if the client is pretty sick, because they're not going to be able to make it every single day to the office. And of course, part of this has to do with what is the transit, how close are they to the physician's office. All right, if you are going to use a benzodiazepine on an office-assisted outpatient alcohol detox, then which benzo might you use? Now, the one driving variable as to which benzodiazepine physicians or prescribers like to use is their prescriber preference. What are they used to? What do they like to use? And the big three continue to be lorazepam or Ativan, diazepam or Valium, and chlordiazepoxide or Librium. So you see the chlordiazepoxide being used, especially in prescribers that are over 55, 60 years old. That's their old tried and true. It is the granddaddy of benzodiazepines. My editorial comment here is let's avoid alprazolam and clonazepam. We could use either one of these, but I see them as a poor benzo to use, especially Xanax or alprazolam. Klonopin, there's a fair amount of clinicians that do use it. I just find it a difficult medication to taper off of. I guess it might just be my own bias. When we're using a benzodiazepine in an outpatient alcohol detox in the office, you are relegated to relatively low dosing. And the dosing that I describe here, I consider it low dosing, but in fact, physicians or prescribers that order this might see this as in fact high dosing. And that is that you might start out with lorazepam 1 milligram QID on day 1, TID on day 2, BID on day 3, and QD on day 4. The diazepam and chlordiazepoxide, that's similar. We do like to look at what is the equal dosing between benzodiazepines, and we use a formula of 1 milligram of lorazepam equals 10 milligrams of diazepam and 25 milligrams of chlordiazepoxide. So you can use all of these as a QID, start with a QID, drop down to TID, BID, and QD. But I see those as relatively low dose. And if they are working, I suspect it is because the person was not highly dependent on the alcohol use. Okay, so we're jumping now to nurse supervision in the home. And there's a number of ways that we can have nurse supervision in the home. This is more, we're moving towards a concierge level, although there are a number of programs that have partial visits or just daily visits. So you might have a daily visit for the nurse in the home. You might have multiple daily visits where they come in 2 to 3 times a day. And then you can also have 24-hour nurse supervision. Within the daily nurse visits and the multiple daily visits, you might also have accompaniment of a nurse's aide or companion. There are a lot of programs out there that just operate with a companion in the home as opposed to a nurse, and the doctor or the nurse practitioner or physician's assistant is prescribing the medications, and the companion is the only person on site that is observing the client and possibly giving the client the medications. I frown upon this greatly. I know that it can be done. I know that the companion may certainly be even more superior than a family member. But my concern there is that if something goes wrong or awry, not only will there be liability for both the companion and the prescriber, but the companion would be, by going wrong, I mean, if the client were to die for some reason or another, or to be injured seriously, it's a terrible thing to have to live with. And I would hate to throw that on the companion and the prescriber. So again, just my editorial comment on companions. So there are variables to the efficacy of nurse supervision in the home, and these may include licensure. Do you have a nurse practitioner in the home? Do you have an RN in the home? Do you have an LPN in the home? There may be a different knowledge base among those three. And in addition to that, there's the ability to interpret orders or to follow through with the orders in different ways, depending on licensure. Also, you look at the experience level to the efficacy. You know, is this an office-based nurse? Again, going back to familiarity, is the office-based nurse being thrown into a situation in which he or she has not been asked to do this before, but in order to cover their derriere, they may be sending in a nurse just to see how the person's doing, take some vital signs, something like that. And the nurse may or may not be adept at picking things up, picking cues up. Is the experience level that of a specialist? Is this something that nurses do on a consistent basis? Again, having a lot of familiarity and experience. And is the nurse certified in this arena? Are they certified as a addictions nurse, or are they certified in possibly mental health? Those are variables. How much time is spent with the client? How much time is spent in the home? If you go in and spend 5 minutes with the client, what's that going to be like compared to spending an hour with the client or longer? Now, these are all obvious variables, but they're things to think about when we're engaged in an outpatient assisted detox. And then with a nurse supervision in the home, we may be a little bit more comfortable using the breathalyzer. Certainly we can use a sober link on a consistent basis, but those are quite expensive and the client may not have that kind of access. But the nurse could do a breathalyzer consistently. I do know clients can time their drinking around when they think a breathalyzer is going to be used. Technically, you can be down to a level of 0 after 12 hours from having a drink. So just be aware of that when you're using breathalyzers. And I think everybody on the call probably knows what a sober link is. If you don't, you can throw that into the chat and we can try to be more specific. All right, going back to the support network, we're looking at, how aggressive an outpatient detox can be. So we covered some of these. I'm going. So if you have the support network that we're looking at, if you're doing intermittent visits rather than on-site 24 hours a day, then we're looking at, you're still looking at a fairly low dosage of benzodiazepines when you're doing your intermittent visits. My suggestion would be that you're still limiting yourself to at or about 4 milligrams a day of lorazepam, as opposed to if you have a nurse on site 24 hours, whether that's a nurse, one nurse on site the full time doing private duty nursing, or you have 2 nurses on site doing 12-hour shifts. You can increase the dosing from 4 milligrams a day easily to 10 milligrams a day. We have actually used up to 16 milligrams a day on site when we've had a nurse on site. Diazepam intermittent visits, I would still limit to 40 milligrams a day, day one. And however, easily we could go to 100 milligrams. We've gone to 200 milligrams, but you could easily go to 100 milligrams with a nurse on site. And chlordiazepoxide, certainly limited to 100 milligrams a day if you're having intermittent visits. And you can go, again, you can bump it up to 250 milligrams or even higher if you have a nurse on site 24 hours. Let's see here. That's just a comparison, I believe. All right, we've blown through this pretty quickly, so we're going to have time for some questions. But we've been talking a little bit, very generalized, about outpatient assisted detox in the office, outpatient detox in the home. And we've focused on medications because that's a primary area of detox. However, this is also an opportunity to get to know the client or the family. And no matter if you're doing it in the office or in the home, you have this opportunity. You should make every effort to again observe the client, observe the family. What are they like when they come into the office? What's their actions? What kind of connections might they be making? How can you ally with them so that you can try to move them towards sustaining their sobriety? In the home, when we're doing our 24-hour in the home, it's really an opportunity to get to know the client like no one else. You become what I call professionally intimate with the client, and you see the goings on in the family and in the environment, and you can really make some significant changes. You can also ally with the client so that they trust you greatly. And speaking of trust, you want to make every effort to have continuity of caregivers. This is especially true when they're doing the detox in the office. Excuse me. If they come in for 3 or 4 days straight and they see 3 or 4 people, you're missing a great opportunity to connect with the client, and you're missing a great opportunity to have an impact on them on their ongoing sobriety. At some point in time after the detox, I would highly suggest that you literally hand off the care to anyone taking over. You just don't give them a name, but you actually connect with them in some way, shape, or form. Connect with the caregiver that you're handing off the care to. And then make ongoing care part of the expectation. What I mean by that is that when you do the detox, so a lot of people think that detox is not even part of alcohol treatment, that it is pre-treatment, that you do the detox and then from then on you get the client into treatment. I certainly don't feel that way. I think it's the initiation of treatment and then you have the next phase. But often a person will go through a detox process like this, and then the physician or the prescriber will not see the client again for a month. I think that's a huge opportunity lost. I think that you should absolutely make it a expectation that the client comes in at least a week, no greater than a week from their last dose of medication. And in fact, if it's at all possible, it'd be great to come in a couple times that week and then weekly for a month. It means a great deal, again, to make an alliance with the client. That, I believe, is what I have here. And hopefully there is either a question or comment, or maybe people can share a discussion.
You can unmute and ask questions, or you can put it in the chat. Fran?
We at Western Psych, when I was working there for 25 years, we did an ambulatory detox. People would get cleared in the emergency room, and then they'd come to our clinic every morning at 7:30. We check blood pressure, temperature, physical stuff, and we'd give them four Libriums and Seroquel for sleep. I kid you not. And then at the end of the treatment, we got them connected with some next stage. Some people went to our local IOP program. Some went to some of the other local drug and alcohol programs. But that's all we ever gave was Librium and Seroquel.
And what how successful did you feel that was, and what was the retention? When
we saw these people, we had no medical crises related to it. And the majority of people took the advice we had in terms of connecting with the next level of treatment that was recommended. So I'm amazed it went so well, thinking back on it.
And what about the screening, the determinant of the screening for the client? Was this open to anyone, or did you screen the client?
It was open to anyone. They had screening in the emergency room. So they had, all kind of lab tests, et cetera, and they had to agree that they were interested in stopping drinking.
Okay.
And we only did alcohol.
All right, Fran, thank you. Yeah, and by the way, this was all just for alcohol. We could get into polysubstance. I didn't want to get into polysubstance. That could cause some concerns. But Ian, can you say a little something about what you just put in the chat?
Hi, everybody. I think you were asking me.
Yes.
Hi. So we do, I've done this in two different programs, East Coast and West Coast, and we do an intensive pre-screen because we really keep the lane very narrow. We want to try and mitigate and reduce all risk up at the front end. So it's a lengthy pre-screen that's specifically for ambulatory detox. It'd be above and beyond sort of the rest of the screening that they use. We absolutely require they have, we call them a teachable caregiver. And they have to come in. And so the way we've done it is slightly lower doses, I think, than we're using Librium. And I did have a question that occasionally we keep Ativan for folks that we think have a more compromised liver function. I believe that Ativan moves through the kidneys. But we require them to come in for the first 3 days. We check in with them every night. And then if they're doing well by the end of that third day, and so we're using a local pharmacy. So they come to the center and then they literally go about 200 yards to the pharmacy and pick up the next day's meds, the evening and the next day's meds. And then as long as they're doing fine on that third day, we'll release the remainder of it's about 2 to 3 days of medication. But you're right, and this is what I've heard, is that the key is the conversations that happen while they're at home about, like, what's your next step? What are you doing on day 6? How can we get you back into PHP or IOP? But for us, it's the pre-screen and narrowing the lane of risk at the front end, because if we identify at the front end, we don't want to be a barrier. So we want to just immediately refer to residential, to an inpatient detox with the partners we have.
Thank you, Ian.
Bill, I have a question about medication.
Yep.
You didn't mention at all about phenobarb. Is
Yep.
that ever used?
Oh, I think phenobarbital is used a lot. And in fact, in a very rare instance, it will be used outpatient in an office-based outpatient program. But the physician or the prescriber, I keep saying physician, so forgive me. I know many NPs are prescribing these days. And so they need to be very comfortable with phenobarbital. With the 24-hour nursing, we have seen it used a lot. In fact, we had a case going on this past week where we used phenobarbital. I've got a case right now with phenobarbital. Phenobarbital is a relatively safe medication if you have the oversight, if you have somebody monitoring it, such as a medical person. I would certainly not encourage use of phenobarbital if you didn't have a medical person on site. Yeah. I don't know if that answers your question. There's also all sorts of different variable processes that you can use phenobarbital. We're looking at a 4-day process right now for a detox, and some people want a 5, 6, 7-day process. But it's a very good detox medication, and we particularly like it when we're combining alcohol and benzodiazepine detox.
Okay, because I was using it. I was doing the admissions for an outpatient residential program, and a patient came in and his blood pressure was very high, and he had just come from a detox program, which is known to not really detox people. So in consulting with the program physician, we started phenobarb, and he would come in and I would give him his meds and check his blood pressure, and he'd go back to the outpatient and the residents, and then come in every morning and do that. And it really worked well. And his blood pressure came in. He really, truly was detoxing then, so it was very successful.
So again, I think most of you all know, phenobarb has a half-life of about 72 hours. So giving it once a day or giving it like that on an outpatient basis may work well. Did you have access to phenobarb right where you were located, or did he have to go get it, or did you have to go get it at a pharmacy, or was it right there?
We had to get it at a pharmacy.
Yeah. So as long as you can jump through those hoops and do that.
Yeah.
How long ago was this, Susan?
5 years ago, maybe.
Oh, I'm impressed that that they had a system in place that they could do that 5 years ago. I think a lot of programs do not have these systems in place. So that's good. I'm glad you brought phenobarbital up. Thank you.
Yeah.
Who's next? Hi, from Dorado, Puerto Rico. Yeah, all right. Good to see you. Yeah. Okay.
I have an interesting situation. I currently am working with a pharmacist who is detoxing from, he's not a heavy alcoholic, but he does drink 10 to 12 to 15 beers a day. He's now down to 7.
So he's
And he cut back
not a heavy.
slowly.
Are you talking about his weight or his usage?
What? He wasn't
Are
a
you talking
no.
about his weight or his usage? Because 10 to
His
15
usage.
beers a day is if somebody was having 10 to 15 shots of vodka a day, they might be considered a heavy user. And 10 to 15 beers is equal to 10 to 15 shots of vodka. So I would say I like to call them bona fide. He's bona fide, but he's down to 7 beers.
He's down to 7.
All right.
And he doesn't want to go into any treatment program because he doesn't want anything on his record.
Right.
So he's doing this on an outpatient basis and using no drugs.
Right. So on his record, what we're really talking about probably is he doesn't want anything on his pharmaceutical record where if somebody
Right.
looks up his name, they see that he's been prescribed Ativan or something like that.
Right.
Yeah, big barrier for a lot of clients. I can appreciate that. We still get clients that request, can my wife be prescribed the medications and I take it? Or can I be prescribed medications as a John Doe? So we get a fair amount of those questions. Yeah. So we do, like a doctor today said, how do I write this prescription? And I should be careful because this is being recorded. But she said, how do I write this prescription? And again, for privacy purposes, and we wrote the prescription for Ativan, diazepam 10 milligrams, Q4 hours, PRN, anxiety. Well, of course, and number 40. And the nurse will be the one that she'll be the arbiter of how to handle this. But that's specific for people that may look on the record and determine that this is not for alcohol, this may be for anxiety or something of the sort. So I'm not encouraging that on your end, Fran, but there are ways that we try to get around that.
Yeah.
We've got about 8 minutes left, so I appreciate it. I focused a lot on benzodiazepines. It is a bias of mine, but there was a lot of discussion about Depakote, about Tegretol, about combinations. And I have always found the use of Depakote, especially 250 BID or 500 BID, to be very effective as an adjunct. When I'm using benzodiazepines. I don't know how other people feel about that. I'm a little hesitant. I don't mind giving 12 milligrams of Ativan in a 24-hour period. I'm a little concerned about giving Depakote 500 BID right away. I like to go up slowly, like 250 BID. But I'm wondering if what others' experiences have been with either Depakote or Tegretol carbamazepine.
No experience.
None?
We never used it. Because this was a while ago.
Has anyone, just shake their head yes or no, has anyone used Depakote during the process of detox? Okay, so years ago, everybody was on Dilantin. I don't know if people are old enough to know that. Years ago, when people came in for alcohol detox, you'd automatically put them on Dilantin. Dilantin was an anti-seizure medication. There was never a study that said that it prevented seizures in alcohol use disorder or in alcohol dependence, but everybody went on it. I think there may be a false sense of safety by putting somebody on Depakote or Tegretol, although there are studies that show that you can actually detox people using Tegretol. So that's where my default is. I also see it somewhat as a mood stabilizer, and it also is good at sedation. It provides some sedation. So I like it especially for people that look to have a mood disorder, and I'm hoping that by initiating it, we can possibly keep them on it over a period of time and steady their mood post-detox as well. So just some thoughts there.
Well,
Anybody? Go ahead.
One.
Yeah,
I
please.
was just going to ask a question about any thoughts on the use of trazodone for sleep in the evening for them.
People using trazodone? Yeah, we use it a lot. We use trazodone is probably the first line for sleep that we use, and then we may also consider using something like a Vistaril, although I'm a little, I think it's a poor man's sleep aid. We'll use Seroquel, low dose, 25 milligrams.
25 mil, that's what we used.
We will also use Zyprexa 1.25 milligrams. Although, again, you're moving into an arena of off-label use. So you have to be careful. Trazodone, for some clients, they complain that it causes very vivid dreams and disturbing dreams. So that's one issue. If I have a nurse on site, I like to use the benzodiazepine to assist with sleep, because that just, to me, gives an added comfort level or added protection against delirium tremens and seizure disorder. Any other nuggets out there that people would like to share regarding your old tricks of the trade?
Adam wrote in the comments, thank you for a great presentation. He's interested in statistics on home and outpatient detox. Or any statistics.
One of the few statistics I have, Adam, is that our clients relapse, about 39% of our clients relapse or slip. And when I did that review, I was highly concerned. And I shared it with somebody that was very interested in our business. And he said, Bill, that's the exact same number that we have. And there's a lot of programs out there that will tell you we have 4%, relapse, or all of this stuff. And so the fact is that's, I like to say regarding our program, which is Executive Home Detox, we're not better, we're different. I mean, we're not better than other programs, we're different. And what I will pride ourselves on is that the client often is not afraid to call us back. They're not afraid to call us back and say, I slipped up, or something happened. My dog died, and I'm in a bad shape. I had a breakup with a boyfriend or girlfriend. I'm in bad shape. Can we jump on this earlier rather than later? I don't see that as a failure. I see that as a success in a lot of ways, because it is a process. It's kind of like going back to the do-it-yourself deal. I don't see do-it-yourselfers as negative. I see it as a process. You were going to say something, Adam.
No, I was just going to ask. I think it's great to hear those numbers. It could certainly be a lot worse, obviously. But I'm wondering what the length of time is between completion of the program and the relapse. If there's any association on that, like whether there's a standard length of time, or and clients, if they give feedback on the process, is there anything linking in the feedback that might be approved upon that might not prevent relapse, but improve? Obviously, process improvement is always being looked at, but that kind of feedback, if there's any of that data is collected.
Our volume, I used to say our volume wasn't enough to do that, because you need 30 units. Our volume is big enough to do that now, and I haven't been doing it diligently. So going back to your original question, the data collected, I've gone back at least 2 years for that 39%. Most people look at that over a year's period of time. Another standard is 30 days. We don't do it out over 30 days. I'll look at it over a 1 year period of time. And the data again that I shared was over a 2-year period of time. Maybe I'll did April? Oh, April, I'll put you on the spot. Any feedback that you get that identifies positives versus negatives regarding our own process, the 24-hour nurse on site?
I think it has to do with not just the detox, but what comes in after. There's a lot of articles out there about what you do after. If you go, I call it solo or being an island. If you go by yourself and you detox and you think I'm done, there's a much higher chance of relapse than if you go into a program. And they go the 30, 60, 90, it used to be 30 days that you focused on detox, go to AA for 30 days, you're done. But now it's more in the 90. So it's what are you going to do in the next day, day 6, day 7, you looking at that. And that links into what support they have will directly link into their relapse. I know many of you probably know all about Memo to Self or Pleasure Unwoven. Those 2 videos are old now, but those are phenomenal videos about addiction and the relapse and chance of relapse and how to protect oneself from relapse. But in the 24-hour, I do this. And so I use all of those. I often, I know I'm going off what Adam is saying, I was just going into, in day 4 and 5 is where the mental health comes into play as well, where that's where I'm starting to look at is the detox doctor, are they going to be moving into treatment mode? So are we, now is the detox completing? Should we look at what might be ongoing medication for treatment and our medication assisted treatment? So there's detox, acute phase, and there's like subacute and then post. And so in the beginning, heavy detox, you know, that's where you're giving most of the meds. But then by day 3, that's where the conversations are really happening and finding out what the doctor's willing to do. And that's where treatment. So, and I don't mean just treatment, like, are they going to go to an IOP or PHP? It's also mental health treatment. And I'm certified as a psychiatric mental health board certified RN as well as CARN. So I automatically go there when I am wanting to know, because if we leave them untreated, depression untreated leads to relapse. Anxiety untreated leads to relapse. So if you don't treat, they're going to relapse. So so they don't feel discomfort. So that's where I think what we set up after and what the doctor's willing to do, or I shouldn't say doctor, the prescriber, whomever they're working with, what the client is willing to do, as well as the people around them are willing to do. I don't know if I really answered. I don't know if I answered your question, but.
I don't know if there is an answer for my question. I do know that one of the things I was thinking early on in Bill's presentation, when you're assessing the individual, whether it's the right environment or the right individual for home or outpatient detox, looking at the support structure obviously is going to be key for if they're living with a spouse or a partner that is also using alcohol or something. How is that environment going to change? Is there support structure, people willing to change their patterns of behavior in order to support this person who, once they complete that program? Obviously, if that person is staying in the household with them and they're not changing, odds of relapse, I think, are pretty obvious. You know what I'm saying? Mm-hmm. So all of those pieces are key. And I think you're right. The mental health component is huge. If you're suddenly sober, and the rest of you hasn't been treated, what are the odds you're going to stay sober if you haven't done anything to treat the other things that are driving your mental health at that point? So I think it's hard for somebody who's newly sober to tackle all that.
Thank you, Adam, and thank you, April. I want to piggyback on something April said, and that is day 3, day 4. Yeah, you know, if we can take care of the client day 1, day 2, and we can allow them to either trust us or allow them to know we are going to care for you if there's a concern, then that's the focus for day 1, 2, 2.5. That allows them to hear you on day 3, day 4, day 5. So, you know, that it always kinds of interests me on inpatient detoxes where clients are required to go to groups, but we're sedating them. And then when they don't follow through with what we want them in group to do, we think that they're not following through. My sense is let's take care of them the first 48, 72 hours, and then shift them to, okay, where do we go from here? And where can they hear us now? Now that they know that they're feeling better, and also that they can trust us that we're going to take care of them and make them feel better. So thank you for that, April. I know time is, we're at time, so I'm happy to stick around. But thank you.
Any other questions last minute?
I'll leave people with this. I just went to the ASAM conference. My wife went with me. Some of you know my wife came down with COVID at ASAM. So normally she sticks her head into here. But I actually commissioned a portrait of us while we were down there. I had a good year last year, so I decided I'd commission a portrait. And it's actually, I think, the nicest portrait I've ever seen of myself. And she looks pretty good too. That's yeah. So
great.
Anyways. All right.
Thank you, Bill. That was a really
Thank
great
you, Bill.
presentation.
Thank you.
Thank you.
Created
Thank
a
you
lot of
for
good
attending.
discussion.
And it's
Thank you,
great to
everybody,
see
for
people.
attending.
All right.
Fill out this survey when you get it on your email, and then you'll get your certificate.